Welcome back to MLT 130. In this lecture series, it's going to be divided up into 3 parts, and in this first part, we're going to be talking about liver anatomy, function, and also different categories of jaundice. Here are the objectives for this lecture. If you would like to pause and read through those on your own, you can at this time. Let's first review some liver anatomy. The liver is the largest organ inside the body. It's located in the upper right quadrant, just below the diaphragm. It consists of 2 lobes, and it receives blood from the hepatic artery and the portal vein. Thus, it's a dual blood supply. So let's look over here at our diagram of the liver on the right-hand side. Here is that hepatic artery, so it's receiving fresh blood from the heart. And here is our portal vein, so blood comes from the intestines. So that's that dual blood supply coming into your liver. The structural unit of the liver is known as the lobule, and we'll see an image of what that exactly looks like coming up on the next slide. The sinusoids are vascular open spaces inside the lobule, and we'll be able to see what those look like on the next slide as well. There's some primary cells that make up the liver. There's hepatocytes that make up about 70% of the liver's mass. There's Kupffer cells, which are macrophages that come from monocytes. And remember, those can phagocytize things like bacteria, old red blood cells, toxins. And then we have endothelial cells, but these are not as important to the liver function. The liver is necessary for life. You cannot live without your liver, though portions of the liver can regenerate, and the liver has many functions, and we're going to learn some of those functions coming up in a few minutes. So let's look at this image of the liver so we can zoom in and look at what's inside the lobule. Remember, the lobule is the functional unit of the liver. So we start out here at the liver as a whole, and we zoom in and we can see several lobules grouped together, and then we're zooming into just one of these, one lobule. Okay, and then down here we're zooming in even farther, and we're looking at a little section of this lobule magnified down here. So let's try to identify some structures down in this lobule that's been magnified. One thing that we want to point out that we mentioned in the slide previously is the sinusoid. Remember, there are those vascular spaces or open spaces within the lobule. This is pointing out the hepatocytes. Remember, the hepatocytes make up about 70% of the liver's mass. If any macrophages would presently be hanging out along the inside lining of these sinusoids, waiting to be able to pick up any foreign debris. This long green structure is a bile ductal, or it can also be referred to as caniculi, which means a small canal or duct. And the last thing I want to point out is the central vein area, where everything flows towards and into, and it feeds into the hepatic vein. So let's talk about liver function, and there's 5 categories of liver function, and we're going to talk about each category a little bit more in detail. But there's metabolism, excretion, detoxification, storage, and immunologic functions. So let's first talk about metabolism in the liver. The liver helps maintain stable plasma glucose through converting glycogen to glucose for energy. Glucose 6-phosphatase is an enzyme that allows the liver glucose to enter blood plasma. We have synthesis of most plasma proteins except for hemoglobin and gamma globulins in the liver. The liver takes free fatty acids from the diet and breaks it down into acetylcholine. So what's acetylcholine? It's a molecule that participates in biochemical reactions in metabolism, and its main function is to deliver an acetyl group to the citric acid cycle, the Krebs cycle, to be oxidized for energy production. So this breakdown of our fatty acids to acetyl-CoA produces endogenous cholesterol for cell membranes. The liver also helps with the synthesis of lipoproteins. Now let's talk about the excretion or secretory functions of the liver. The liver can excrete bile acids, cholesterol, and bilirubin through bile ducts for storage in the gallbladder. Bile acids can be used in the small intestine and play a role in digestion and absorption. The liver plays a role in the synthesis of urea from ammonia. Ammonia can be produced by the breakdown of amino acids or by the gut bacteria in humans, but if the level of ammonia in the blood becomes too high, it can become toxic to the brain. So the urea cycle removes ammonia from the blood and makes urea, which eventually can be excreted in the urine. The next function of the liver is detoxification. It can play a detox role of many substances such as bilirubin, alcohol, and drugs, and these can be recreational drugs or prescription drugs. The liver serves as a filter. The fourth function is the liver can act as a place of storage. The liver can store glycogen. It can store iron needed to produce hemoglobin. The liver can also store copper, and it can store fat-soluble vitamins such as A, D, E, and K. The last function that we're going to talk about is the immunologic functions of the liver, and the Kupffer cells are involved in this function. And the Kupffer cells phagocytize bacteria and other substances. Remember, those Kupffer cells are macrophages, and those macrophages come from monocytes. Thinking back about our white cells. As part of the immunologic function of the liver can secrete IgA. Remember, IgA is the most abundant antibody in the body. It's the line that is responsible for secretions in the mucosal tissue, and it can help prevent against infections of microorganisms. So the IgA is used for immunodefenses. And if you look down here, this is again part of the lobule, a zoomed in little section of the lobule. Here is that open area or the sinusoid. Here would be that central vein area where everything flows to. Here are your hepatic cells, your liver cells, and this is a duct or a caniculi represented by the green. But if you look here, and I tried to point it out where they would be located, there weren't actually any on the previous slide where we looked at this, but the Kupffer cells or those macrophages would line the inside of the sinusoid. So they would kind of lay in wait, ready to phagocytize anything that they would need to, any kind of foreign or infectious microorganism. They would lie in wait there in the sinusoids within the liver and help with defense. Here's our first review question. Try to answer it on your own before you move on to get the correct answer. Which of the following is a liver enzyme that is instrumental in allowing glucose to enter the bloodstream? Pause the video at this time, answer it on your own. The correct answer is D. Now let's discuss bilirubin metabolism. Our urines class and our chemistry classes kind of go hand in hand here. Bilirubin is a waste product the liver helps eliminate. So we're going to have to review degradation of red blood cells to bilirubin, urobilinogen, and urobilin for excretion. So on the next slide, we're going to look at that same chart of red blood cell degradation that we looked at in hematology. So as promised, here's that breakdown of red blood cells that we looked at back in hematology. This is our spleen, and these are our little red blood cells within our spleen. Remember, our spleen takes out the red blood cells. So this particular red blood cell has an X on it indicating that that cell is being taken out. Well, when you get down to taking these red blood cells out and piecing them out into different parts, you end up with your iron, your globin, and your heme. Your globin can go on and be recycled into amino acids. The iron can be recycled into ferritin. And the heme is going to go on through a process and be converted. And right here, you're going to have biliverdin. From there, you're going to have the free unconjugated bilirubin in blood circulation. And then you're going to go on and have the conjugated bilirubin in the liver. And from there, the conjugated bilirubin can move down via the bile duct into the intestine, where it will be converted to urobilinogen using the normal flora bacteria that's present in the intestine, and then it will eventually become urobilin. But we'll cover all these steps in a little bit more detail in the coming slides. But I did want to review this image because we had looked at this image before, or this flow of how the degradation happens in hematology. So again, the old red blood cells die and they're removed by the spleen. The iron from the hemoglobin molecule is returned to the liver for storage. The globulins from the hemoglobin get to go to the amino acid pool. So they're recycled. So now we're just left having to deal with the heme from the hemoglobin molecule. So we have to break it down. So the heme is converted to biliverdin, and always think green when you hear biliverdin. The biliverdin is converted to indirect or unconjugated bilirubin. Then the unconjugated bilirubin is transported to the liver via albumin. Remember, our albumin is a protein. Unconjugated bilirubin is water insoluble and makes up about 80% of the total bilirubin in plasma. Unconjugated bilirubin has an affinity for the brain and nervous tissues, so large amounts can cause brain damage. This is a condition called kernicterus, and this often happens in infants with abnormally increased bilirubin levels. In the liver, bilirubin is conjugated with glutaric acid via an enzyme UDP, which is uteral diphosphate glutarinyl transferase. Conjugated bilirubin is also referred to as direct bilirubin, and this form of bilirubin conjugated is now water soluble, so remember that. It's water soluble. Direct bilirubin is excreted via the common bile duct into the duodenum, which is the first part of the small intestine. The small intestine's normal flora or bacteria reduces the bilirubin into urobilinogen, which is colorless. The urobilinogen is then oxidized to urobilin, which is the red-brown that is excreted in stool. Now let's talk about urobilin in the urine. Most urobilinogen is excreted in the stool, but about 20% of urobilin is reabsorbed through the portal circulation through the liver and then returns to the gallbladder and intestines. In this process, a small amount of urobilinogen is excreted also in the urine because blood is filtered by the kidneys. Thus, it would be abnormal to have no urobilinogen at all in the urine. So if you think back about MLT 110 or even MLT 111 when we were talking about the dipstick that we do your analysis on, what's the lowest amount of, or a normal measurement for urobilinogen on a dipstick test? If you remember back, a normal reading is 0.2 on a dipstick. Again, this is just another diagram, another breakdown of those red blood cells into the different products through the liver and the intestines and so on until you have what's excreted out through feces. I just wanted to include this. This one might be a little bit more helpful than the other one that we looked at. but it's against the same information that we've been talking about in the last few slides. So let's do a little trivia and check ourselves. In a condition connectorus, the normal accumulation of bilirubin occurs in which tissues? So try to answer this on your own, or pause the video before you go on and get the correct answer. The correct answer is A, the brain. One more trivia question. Name the enzyme that is required for bilirubin to become conjugated in the liver. Try to answer this on your own before you go on to get the correct answer. The correct answer is D, UDP. Now we need to talk or discuss some pathological hepatic conditions. First off, let's talk about jaundice. Jaundice is a physical symptom of liver disease. You will see yellowing of the skin. You can also see yellowing of the white of the eye and also the mucous membranes. It's usually not apparent until the total bilirubin is increased to 2 to 3 milligrams per deciliter. The normal range for total bilirubin is 0.2 to 1.2. We can test for the total bilirubin, which is the unconjugated and the conjugated, but we can also specifically test for the unconjugated and conjugated. We place jaundice into 3 different categories: prehepatic, hepatic, and posthepatic, and we'll talk about each of those categories in the coming slides. But first, let's talk about another condition that can cause yellow skin: hyperkeratonemia, which is a condition where plasma carotenoid levels are elevated. Carotenoids are fat-soluble plant nutrients responsible for red, orange, and yellow colors in our fruits and vegetables. This condition is indistinguishable from hyperbilirubin. The sclera, or the white of the eye, is not discolored. There is no yellowish color in the eye. So this is different than our true jaundice patients that will have a discoloration and will show a yellowish color in the white of the eye. So let's look at some examples of jaundice. What does it look like? We also refer to jaundice as icterus. Remember our blood samples when we spin them down and the serum or plasma has a strong yellowish to greenish color, we refer to it as icteric. So with jaundice, you can have a yellowish discoloration to the skin, the mucous membranes, and the sclera, or the whites of the eyes. So let's look down here at deposition of bilirubin in this infant. You can see how yellow the baby's skin looks. Also, here's an older patient that's having some liver problems, and you can see how yellow the skin is, and also the white of the eyes on this patient appear very yellow. Remember we said previously that you can categorize jaundice into 3 categories. Let's first talk about prehepatic jaundice. This is from disease resulting in an increased breakdown of red blood cells or hemolysis. The liver is function is just an increased overload to the process. In prehepatic jaundice, you're going to see an increase in unconjugated bilirubin or indirect bilirubin and total bilirubin. Why? Because the excess bilirubin is reaching the liver and cannot be excreted. Thus, unconjugated bilirubinemia occurs because the liver is unable to process the increased bilirubin load. So, some examples of prehepatic jaundice include our hemolytic anemias, hemolytic disease of the newborn, and blood transfusion reactions. These are all because of an increase in red blood cell turnover. Congestive heart failure can also cause prehepatic jaundice because congestive heart failure causes impaired circulation, so bilirubin does not reach the liver to be conjugated and eliminated. So we have a think about it situation here for our prehepatic patients. If a patient has hemolytic anemia, they will develop prehepatic jaundice. They will have increased total bilirubin and unconjugated bilirubin in the plasma, but will they have increased bilirubin in the urine? The answer is no. The increased Hemolysis causes increased unconjugated bilirubin in the plasma, but urine bilirubin on the reagent strip for urine is going to be negative. Unconjugated bilirubin is complex with a larger protein of albumin, and this cannot pass through the glomerulus and into the urine filtrate. Since albumin is a protein and proteins are normally too large to filter through the glomerulus, you're not going to be able to see the bilirubin because it's stuck to that albumin. So your urine reagent strip for bilirubin is going to be negative. Here's another review question. What substance gives feces its normal color? Pause the video, try to answer it on your own before you move on and get the correct answer. The correct answer is D, urobilin. Here's another think about it question. If a patient has increased rate of hemolysis, what would you expect to see on that patient's urine urobilin result? Would it be normal, increased, or decreased? Try to answer it on your own before you move on and get the correct answer. The correct answer would be B, increased. Now let's talk about that next category of jaundice, hepatic jaundice. This is due to a problem occurring in the liver. It can be from a genetic problem, genetic disease, cirrhosis, viral hepatitis, or alcoholic liver disease. Hepatic jaundice can also be seen in newborns because of immature livers. The enzyme UDP might not fully be functional at birth. It's usually not functional until 2 to 3 days after birth, and often babies require UV light therapy, and the UV light helps break down the bilirubin. If you look over here to the right, you'll see a baby in a little chamber, and it's undergoing UV light therapy to help break down bilirubin. So let's think about this situation. If we know that newborns, the enzyme UDP is not fully functional at birth, a lot of times our babies may be jaundiced. So what type of bilirubin do you expect to be elevated and why? We would see an increase in our total bilirubin in our babies, of course, and the unconjugated bilirubin in blood because the baby is still deficient in the enzyme needed in the liver for conjugation. We also know that unconjugated bilirubin has an affinity for tissues, for nerve tissues, especially brain tissue. So if the baby is not placed under a UV light for light therapy to help break down the bilirubin, the baby could have brain damage if that bilirubin is not addressed. So that's why it's so important for us to take care of those babies and try to get rid of those jaundice situations. Jaundice into two separate groups, those with increased conjugated bilirubin and those with increased unconjugated bilirubin. And we'll talk a little bit more about those later on. But in hepatic jaundice, the liver is the area that is impaired. Thus, it is categorized as hepatic jaundice. So the third category of jaundice is post-hepatic jaundice. Overall, this is also known as obstructive jaundice. This is blockage of the bile flow from the common bile duct. It can be from gallstones, and that's the most common cause. Less common causes are because of a cancer or a tumor in the bile duct, or stenosis, which is the narrowing of blood vessels or a valve to reduce flow. In this particular type of jaundice, the liver is functioning properly. So in this particular jaundice, you're going to see the conjugation of bilirubin. So it's made it past the liver at this point, the bilirubin. And this is just showing, this image over here is just showing some gallstones in the gallbladder. In post-hepatic jaundice, the liver is able to conjugate the bilirubin, but the bilirubin cannot leave the liver and get to the intestines due to some type of obstruction or blockage. Thus, there is a backup of conjugated bilirubin into the liver sinusoids and an overflow into the blood. So in the blood, we see an increase in conjugated bilirubin. We also see an increase in bilirubin in the urine. Why do we see that? Because the conjugated bilirubin in the blood is not complex with that large protein of albumin, and thus it can be filtered through the glomerulus and passed through the urine. So in a post-hepatic jaundice patient, will we see urobilinogen in the urine of that patient? Why or why not? Urobilinogen would be absent in a patient with obstructive jaundice. Why? It's due to the blockage in the common bile duct. The bilirubin never gets to the intestines. Normally, about 20% of urobilinogen is reabsorbed from the intestines to the blood to be filtered by the kidney. Well, this never happens. But if you think about our urine reagent strips, our dipsticks, they're not designed to detect zero. The lowest amount that they can detect is 0.2. They only detect normal or increased amounts of urobilinogen. So you cannot just rely on a reagent strip method. The provider must order a quantitative test for urobilinogen to confirm there is zero urobilinogen in urine. So the doctor or provider is going to have to order a more sensitive chemistry test to get that answer of zero urobilinogen. It cannot be done with your regular old urine reagent dipstick. What would we expect to see in the feces of our patient with obstructive jaundice, and why? For the appearance of feces, you're not going to have that normal brown pigment. Remember, the brown pigment comes from urobilin. Remember, the urobilinogen has to be oxidized to make urobilin. Well, that process is not going to happen in an obstructive or a post-hepatic patient. The common bile duct blockage prevents the bilirubin from entering the small intestine to be converted to urobilinogen. So the patient will have gray or clay-colored stool in obstructive jaundice. They're not going to have the normal brown pigmented stool. So here's our last trivia question for this section of the lecture. A patient presents to the ER with jaundice, abdominal pain, and vomiting. The urinalysis reveals an increased urine urobilinogen result. Which of the following are likely exempt? Pause the video at this time. Try to answer it on your own. The correct answer is C, cholelithiasis, which is gallstones. This concludes part 1 of the liver lecture. I will see you over in part 2. If you have any questions or need any further clarification, don't hesitate to reach out.